Welcome to Medical Logistics 101, Rashes Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold and to explain how clinicians think through these problems in resource-limited settings. Rash descriptions. Macula is a flat, non-palpable area of color change. Example would be freckles and flat drug eruptions. A patch is a large macula greater than 1 centimeter, flat with color change. Examples vitiligo and large caffeolate spots. Papule is a small raised solid lesion less than 1 centimeter. Examples eczema, flares, and lichen planus. Plaque is a raised flat top lesion greater than 1 centimeter, often from coalescing papules. Example psoriasis. A nodule is a firm, deeper, solid lesion extending into the dermis subcutis. Example, cyst and some skin cancers. Vesicle is a small fluid-filled blister, less than 1 centimeter. Example, shingles, contact dermatitis. Bulla is a large fluid-filled blister greater than 1 centimeter. Examples, bullous pemphigoid, and severe drug eruptions sometimes have this. Pustule is a pus-filled lesion. Examples, folliculitis, acne, impetigo. A wheal urticaria is where you commonly see wheals. Transient edematous raised lesion that migrates. Example, hives, rapid onset usually. Petechiae is a non-blanching pinpoint hemorrhages, kind of a red flag for vasculitis, thrombocytopenia, and meningococcemia occasionally. Purpura, larger non-blanching hemorrhages. Examples, palpable purpura equals vasculitis unproven otherwise. Scale, flaky, keratinized epidermis. Examples, eczema and psoriasis. Crust, dried serum, blood, or exudate. Examples would be impetigo, where you get that honey-crusted lesion at those sites, usually around the mouth, facial areas, but can be other areas. Erosion, superficial loss of epidermis. Examples, ruptured vesicles. Ulcer, deeper loss of epidermis plus dermis. Example would be pressure ulcers, and of course there's various staging for pressure ulcers. Signs of symptoms, onset type, sudden versus gradual. Symptoms, is it itch? Is there pain? Is there burning? Do they have systemic symptoms like fever? Distribution, localized versus generalized, flexor versus extensor surfaces if you're talking about the extremities. Is it in a dermatome pattern like shingles, which would usually be on one side? Sun-exposed areas and pressure areas. Morphology, macular, papular, vesicular, pustular, urticarial, petechial, purpuric, the terms we just discussed. Exposures, history, new medications, have they started any new medications? Infections, recently, allergens, chemicals, plants, heat, friction. Really have to take a detailed history when dealing with rashes like this. Systemic clues, fever, mucosal involvement, joint pain, respiratory symptoms, GI symptoms. Exam findings, as far as primary lesions are concerned, again, macules, papules, plaques, vesicles, bulla, pustules. Secondary changes would be like scale, crust, or excoriations. Distribution clues, dermatomal patterns, you see that with shingles. Flexural, you see it with eczema, extensor, psoriasis. Sun-exposed areas, lupus, photodermatitis. Pressure or friction areas, contact dermatitis, and seen with urticaria. Exam findings, is there mucosal involvement? You see that with Stevens-Johnson syndrome and toxic epidermal necrolysis. Also see it with erythema multiforme major and Kawasaki disease and viral exanthems. Palpable purpura, vasculitis, unproven otherwise. Basically, you're wanting to really describe the rash, the history, of course. It's multiple things that you're taking into account, not just what you see on exam. Diagnostic studies, labs, CBC, CMP, erythrocyte sedimentation rate, C-reactive protein is sometimes ordered. There are other specialized tests, of course, but typically for me, not something I would order. That's more of the dermatology field. Infectious testing, strep, mono, HIV, syphilis. Sometimes order tick panel if there's a history of that. Skin scraping, potassium hydroxide. Quick test you can do if there's ever a doubt whether or not a reaction, the rash is fungal. By adding the potassium hydroxide, you can see the hyphae under the microscope and confirm that. Biopsy, when the morphology is unclear, is it chronic? If there's a concern for skin cancer, certainly the biopsy is totally appropriate. Imaging, rarely needed unless you're looking for some sort of systemic disease in association with the rash. Patch tested chronic or recurrent contact dermatitis. Acute rashes, these would include contact dermatitis, urticaria, drug eruptions, viral exanthems like fifth disease, shingles, cellulitis, and acute petechiae or purpura. That's a major red flag and seen with things like Rocky Mountain spotted fever and others. Chronic rashes obviously include eczema or atopic dermatitis, psoriasis, seborrheic dermatitis, rosacea, chronic fungal infections, see that quite often, autoimmune rashes, lupus, dermatomyositis, lichen planus, or chronic urticaria. Red flags for me would be fever and a rash. It's going to make me want to investigate further and see what's going on. Mucosal involvement, petechiae or purpura, again, Rocky Mountain spotted fever comes to mind. Rapid progression, example, that would be necrotizing fasciitis, a very dangerous condition. Painful rashes, immunocompromised patients, such as HIV patients, you need to certainly be on guard with those. Bulla or skin sloughing. If there's hypertension or toxic appearance, does a patient look toxic? Are they febrile? They look very sick, and they have some sort of associated rash, then they're going to obviously need much further workup. Pitfalls, treating cellulitis when it's contact dermatitis or stasis dermatitis. You'll see that a lot in some patients in their lower extremities. Missing drug eruptions in patients on multiple medications. Assuming eczema when it's actually fungal. Missing the SJS or TIN. Must catch those early. Missing associated systemic symptoms, especially with Rocky Mountain spotted fever or other vasculitis type symptoms and rashes. Disposition, home with close follow-up. Most acute rashes without red flags can go home with close follow-up. Dermatology referral, especially if it's chronic, if it's unclear, or if it's a treatment-resistant rashes. Urgent care and ED. As far as rashes are concerned, you need to, if you got fever and a rash, obviously they're going to need further workup. Mucosal involvement, that would be like Stevens-Johnson syndrome or toxic epidermal necrolysis. Petechiae, purpura, again, thinking about Rocky Mountain spotted fever, and you sometimes will see a similar type rash with meningitis. If it's a rapidly spreading rash like that necrotizing fasciitis, you would need to certainly be seen urgently. Admission for Stevens-Johnson syndrome, a toxic epidermal necrolysis, severe drug reactions, vasculitis with systemic involvement, immunocompromised patients who have an unclear rash. Those would be reasons I would certainly consider admission. Closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.